so I'm giving a talk for today, which is excellent, on the simplification of hepatitis B care. And I guess what I'm going to say is, you don't have to agree with me, okay? But I'm really asking a question for people to think about this. And Nicholas also set the scene with some of the WHO guidelines, but just something to think about. So the simplification of hepatitis B care, and are we getting it right? Why is this important? Because mostly I always ask the question, why should we care? Okay, I think it's always really important. Why should we care to simplify hepatitis B care? Well, the question could be asked, why not? Because maybe we've started in the wrong place, where it started off complicated, so it should have been simple, and people should ask, so rather than why should we simplify hepatitis B, I would say why not? Because in fact, it should be probably pretty simple. We just started off in the wrong place. Often we start journeys in the wrong place and think that because we started over there, we kind of have to stay over there, but maybe we should have started in an entirely different place. And also, why is it important if we're going to achieve hepatitis elimination globally? And I think this is a really critical thing for people to think about, because we're not just talking about places like Switzerland, we're not just talking about places like Australia, we're talking globally. And as Son really nicely pointed out, there are people from Vietnam, high endemic countries, and are we actually in the West making the lives of other people in the globe really complicated? So why is it important for our patients? Because at the end of the day, this is about people and the story of, in my view, whether our patients get given choice. Nicholas showed this slide. There is stacks of hepatitis B globally, and in some places more than others, and in some places doing well, and in some places we don't even know much, like if you look at all of the white spaces in the parts of Africa there. And in some places we are doing a lot better, but still a whole lot of people are dying, and in my view, entirely unnecessarily related to hepatitis B. And it's because we're not doing enough. And we're not doing enough in part because we've got ourselves confused, but I'll come to that. Nicholas talked about the targets, and there's some absolute targets these days. So why do I think we can achieve elimination? Because we have a fantastic, highly effective vaccine which stops people from getting infected. I think it's really important that we understand this. And critically, most of the cases of new infections globally occur due to mother-to-child transmission at or near births. So that's the first thing. And giving a birth dose vaccine can stop new infections, but in many countries in the world, this is simply not happening. And we have to ask ourselves why, and we have to say, what pressure do we, as people that come from high-income countries, have to try and influence decisions by our government, to fund Gavi, to make sure that the donations and the replenishments actually happen? And I'm sure many of the people in this room are leading clinicians, leading public health officials and the like. So each time Gavi goes for replenishment, we need to be saying this is really important. Because in fact, if we want to reduce hepatitis B in our countries, say in a country like Australia, and I suspect it's the same in Switzerland, the most likely way somebody has chronic hepatitis B in Switzerland is because they migrated here from a high endemic country. So the best way we get to control hepatitis B in the long run in our countries is to be supporting the birth dose in countries where there's still significant mother-to-child transmission. And making sure also in our own systems that we've got it right. There should not be one case in Switzerland. There should not be one case in Australia. There should not be one case in high-income countries of mother-to-child transmission of hepatitis B, but there still is. They slip through. Why can we achieve elimination? Because we've got fabulous medications. And I'm not even talking about cure. And there's kind of stuff coming through with cure. I'm talking about actually the current medications we've got, tenofovir and entecavir, are highly effective. They stop people from getting sick and they stop people from dying. And I think it's really important that we understand that. Putting our patients on tenofovir or entecavir stops them from getting sick. It doesn't absolutely stop them from getting sick, but it stops that. And also it stops them from transmitting infection. The reality is progress is stalled. So this is work by Homi Razavi's group. And essentially it's saying we're not doing a very good job here, okay? And we need to do better. Because as Nicholas indicated, less than 10% of people globally are diagnosed and less than 5% are on treatment. And diagnosis is not expensive. A hepatitis B surface antigen test is not expensive. A hepatitis B DNA test is expensive, and I'll get back to that in a moment. But to actually diagnose hepatitis B is not expensive. And globally, we're not doing well enough. And there's a few things with this. So number one, there's birth dose vaccine. It is not an expensive vaccine. Second, you need to give the 3 doses. Third, in some countries, if you can afford it, you would give immunoglobulin. But critically, in a number of countries where you could afford it, there's not enough people, women, on tenofovir in the 3rd trimester. And I'm going to speak to that in a moment as to why that might be the case. Why aren't women on tenofovir? At least the 3rd trimester. Now, you'll see that I have even a broader argument than that. But we're failing here on something that we should be just being successful at. So why are we failing? We're failing because there's a lack of awareness, despite one of the best vaccines that's ever been developed. Not everybody knows it exists. And I'm sure that we can include some of the policymakers in that. And we're failing because there's confusion, in my view, about treatment. And Nicholas alluded to this. And there's more updated guidelines and various things. But an easel, I tried to get them, but you have to go through their paywall and the like. But the simple thing I want to put across here is all of these guidelines are different. All of them are different. So ASLD, the American guideline, the Asian guideline, the European guideline. Now, whenever I see anything that is different in medicine, that we can't actually get agreement, it means that the evidence base on which they're based is invariably a little bit shaky because we can't all agree in rich countries. And I always then prick up my ears when I look at it because I'm a lazy person. I'm a very, very lazy clinician. And I don't want to read extensive guidelines that confuse me and aren't consistent, because if they're not consistent, if the evidence was really clear, each of these guidelines would say exactly the same thing, but they don't. Current guidelines are just a little bit complicated. WHO's recommendations, also, in my view, the 2015, complicated. I get bored reading it about halfway down. I go, who's actually going to do that? No wonder we have so few people globally on treatment. And particularly when, and I can't remember what my next slide is, but I'll come to it, is that even as we're trying to make them simpler, and so this is Ethiopia's, and I was recently in Ethiopia sort of looking at some of the hepatitis C work, actually with John Dillon's group's doing some really great work in Ethiopia around trying to understand what's going on in simplification of care for hepatitis C in Ethiopia, but I was also giving a talk about hepatitis B. So Ethiopia is trying to make theirs simple. But for many low and middle income countries, the cost of testing is still way too expensive. So in Ethiopia, to do a Hep B DNA, which was required as part of their thing, depending on where you're up to, a hepatitis B DNA, one test costs more than 1 month's salary for a person in Ethiopia. So that's going to happen, isn't it? Like, just imagine if we're Son and his family and you go, okay, we only need to do 5 hepatitis B DNA tests a year for the family. Mum, 5 siblings, actually 6, now that I'm counting it, 6, there were 6 of you, 5 kids, weren't there? 5 kids plus mum, 6. So that's just 6 months worth of salary just gone. It's not happening. So why are we failing? Because actually we're not thinking hard enough about the lived reality of most people in the world, in my view, with hepatitis B. As I said, average monthly salary. So this is the cost of a DNA test, and that's the average monthly salary. So why aren't people in Ethiopia and other places in Africa where people are dying of hepatitis B getting treated? Because any guideline that says you should do a Hep B DNA test is not going to happen. And there is, as Nicholas said, no global fund that comes in, like with HIV, and pays for these tests and pays for these treatments. So it's really important to understand the circumstances in which we're talking about. There is not a global fund that is going to rescue this situation. I won't bore you as to why all of that, and that's not my presentation today, but that's just our reality. The other thing to look at here is work by Andy Hill, who does amazing work at Liverpool University, Professor Hill, is basically saying how much do these drugs cost? And so he did a lot of the work to get the drug prices down for HIV and then for hepatitis C. He was the one that was arguing that it's not $1,000 a pill. It's about $60 to $70 a cure when you actually looked at the ingredients. So this is really critical work because it puts pressure on. And this was how you were able to get licensed generics. But have a look for hepatitis B. So I'm talking about hepatitis B today. $29 a year because it's a licensed generic. So now, partly it means that none of the drug companies are interested in it because they're not going to make a whole lot of money from it. And we'll go back to then the argument. But that really says that we should do something. And I don't know where I did that. So, a question. Tests are expensive. We're under treating. We've got a treatment that works. Why don't we just treat everybody? Because it's like pretty confusing. And so how do you help a simple girl like me? You go, can't I just treat everybody? And there's all sorts of rules about it because people go, oh, you can't do that. So yes, I did say, why don't I just offer treatment to everybody? The medications are excellent, effective with minimal side effect, resistance, which is the thing that we really worried about. It's why we had to have drip feeding of medications around the world, doesn't seem to be an issue. There's never been a described case of tenofovir resistance and hardly any entecavir resistance. Lowers cancer risk, and I'll come back to that, reduces progression to chronic liver disease, stops or reduces transmission of mother to child, and reduces other levels of infectiousness. And it's not like HIV where it's U equals U, but it's at U equals nearly U. It's not probably as catchy, does it? U equals U, U equals nearly U. But anyway, you know what I mean. Undetectable is nearly untransmissible. And there's psychosocial benefits. Basically, I won't accidentally transmit this infection to somebody, which is a really big issue, and we could get onto stigma and discrimination with that. Wouldn't it be good to do a trial first? Okay, and I thank Jess Howe, who works with me for this pigs might fly slide. So it's something that we looked at, and a number of us thought, why don't we do a trial first so we could prove that putting people on treatment, if they're surface antigen positive, as opposed to following, I don't know which guidelines we'd like to follow, take your pick, that we could basically do something. But it required decades to follow because you've got to make sure that somebody, like what's your outcome if you're really doing it properly, is the reduction of hepatocellular carcinoma. So if you do a nice trial, required sample sizes and time to follow up, which is very costly and impractical. The drugs are off patent, so pharma were not keen, as in entirely disinterested. So the likelihood of doing the trial, like we've been able to do with HIV and for hepatitis, entirely different thing because it's short acting, it's been impossible to do. You can't get the money up. And so Homo Razavi's just decided in some places we'll just treat. But some of the data sources can help. Scientific studies of early carcinogenesis, high quality longitudinal cohort studies, and modelling studies. So if we can't do the trial we'd all like to do, and I'm a researcher, I'd love to do a randomised controlled trial comparing X to Y. But if that can't be done because it actually is just can't get funding and is not practical because the outcomes are so far away and a relatively small number, really hard to do these kind of studies, let me tell you. So what are we going to do when the evidence is not clear and possibly never going to be clear, as in perfectly clear randomised controlled trial? So let's look at some of the information we have available to us. What do we know? So this is how they describe these phases of infection. We talk about immune tolerance and sometimes immune clearance or immune active, immune control. But if you have a look at it, there's stuff going on all the time. And I actually think that part of our problem with hepatitis B is we use wrong words to describe stuff, because I don't even know what immune tolerance means if, while somebody is being immune tolerant, the oncogenic nature of the virus is still inactive and getting into people's cells. And I don't really know what immune clearance means if it doesn't really clear the virus for the vast majority of people. And I don't really understand what immune control means if somebody's e-antigen negative, but in fact at considerable risk under many circumstances of going on and developing liver cancer. So I actually think part of our problem is that we put names to things to do with what the virus was looking at, which are kind of a little disconnected to the reality of the circumstances of what's happening. And I reckon we should do with some renaming. So carcinogenesis begins early in hepatitis B. HBDNA integration in the genome is pivotal step in HCC, and clonal expansion of hepatocytes, dysregulated immune signaling and gene mutations. Integrations events proportional to viral load. So if you've got a high viral load when you're immune tolerant, whatever that means, frequency of integration sites is associated with a high risk. So highest in Hep B e-antigen positive patients who often the guidelines have been saying we shouldn't be treating. So often not, so often do not currently fulfill treatment guidelines. So whilst we're waiting for somebody to be tolerant, they're busy actually getting some cancer, oncogenic type virus into their cells, which is, in my view, not particularly good. Intolerant IT is not so benign. And cumulative evidence would suggest that HC deaths or transplants is higher in immune tolerant than immune active, sometimes called immune clearance, when they're on treatment. So what we do is we say you can go on treatment now when you're in an immune active phase because your virus is doing this or that or the other. But in fact, what we see is when we put them on treatment, so people who are immune active on treatment get better outcomes than people who are immune tolerant not on treatment. And I ask myself, is that a smart thing? Why do people die from hepatitis B infection? Without treatment, 1 in 5 people go on to get cirrhosis over 5 years. And without treatment, 5 in every 100 get HCC. But importantly, a number of these HCCs occur in people without cirrhosis. So unlike Hep C, where you get basically, in Hep C, your HCC risk really only occurs when you've got cirrhosis. With hepatitis B, it can occur at any stage. And when you begin to add up the numbers of more people with HCC not having cirrhosis, but still being at risk of HCC, you begin to go, again, maybe there's a whole group of people that we're letting just go along and not really thinking actually they're still at risk. It's a lower risk than if they're cirrhotic. It's a lower risk than if they've got a whole lot of virus. It's a lower risk, yes, I absolutely concede that, but it's still a significant risk. And so what we end up doing is that we end up not treating a whole lot of people who still remain at risk of something that we could stop from happening and progressing. So lower liver cancer risks with antiviral therapy in chronic hepatitis B patients with normal to minimally elevated ALT and no cirrhosis. And what this paper showed was clearly that there was a lowered risk if you put people on treatment. Similarly, some work that was done by Homi Razavi, and I'm going to say that this is not a perfect study, but it asks us the question of what do we classify as reasonable risk? And basically, what Homi's group came up with was that hepatitis B and C is highly oncogenic, as I've explained. But also, if you sort of think about what risk are we talking about, it's almost the equivalent of smoking a packet of cigarettes a day. So if we were talking to our patients and saying, you need to reduce your risk of lung cancer, stop smoking a packet of cigarettes a day, we'd all say that's very good medicine. But at the same time, we've got a whole bunch of people with chronic hepatitis B infection, where because their risk is higher over here, if they've got more advanced disease, this, we're actually not saying maybe you could reduce your risk, or at least having the discussion with them. So lower liver cancer risks with antiviral therapy, I think I might have doubled up. Sorry. The other one that got to me, because I'm an HIV clinician as well, is really important here, is that the morbidity in people with Hep B mono infection is greater than the morbidity in people with Hep B HIV co-infection. Now, if one thinks about HIV, they should always win the morbidity race, okay? But the reason they don't win the morbidity race for this with HCC was because when you treat people with hepatitis HIV, you're treating them with tenofovir as a backbone. And so they're on treatment. And again, this gives us a hint as to maybe we're doing things incorrectly. So treatment can stop transmission. And so I'm now going to talk about sort of swinging over in terms of this issue of transmission. Work being done in Cambodia and elsewhere clearly shows a reduction in transmission by putting people on treatment. And work to do with mother-to-child transmission. It's really important. The guideline-based care, and so we're about to do some work in Myanmar, not Myanmar, this work is happening in Vanuatu, I beg your pardon, I do my hepatitis C work and Hep B work in Myanmar, but basically going, as I said, often they do a measure of hepatitis B DNA and assess if the virus is high in pregnant women, then maybe we put them on treatment, but if the virus is low, possibly you don't need to go on treatment. Well, let me explain Vanuatu. Multiple islands in the Pacific, with regular stockouts, like occurs in Myanmar, like occurs in a lot of low-income countries, of hepatitis B DNA tests. Pregnant woman turns up, comes from Ireland over there to main hospital on other island, turns up and they say, oh, your hepatitis B surface antigen positive. Good. You should have this Hep B DNA test. So you go, okay, well, how much does that cost? We discuss whether she can afford it. But also maybe she's gone back to her island before she got the surface antigen test result. Then she comes back and has another test, which gets sent off to somewhere else where maybe she gets that test done, or maybe there's been a stock out. And maybe by the time she gets her result back, she's delivered her baby, or maybe she never did the test because she couldn't afford it. So you can have your guidelines, but your reality is markedly different in many countries as to whether or not these women, even if they are hepatitis B DNA, rip-roaringly high viral load, middle level viral load, or somewhere in between your viral load, it's actually not your reality. So we're about to do a study where we're basically going to go, if you're screen surface antigen positive, then and you're reactive, then we're putting you on treatment. Now, in a perfect world, I'd at least offer them treatment for more than just their pregnancy. But if they're not reactive, no action, and just see what's the impact of doing this. And another group of people, we will be able to go, well, if they don't come back and all sorts of things, they will just do standard of care and have a comparison of those. So reasons not to take treatment. Okay, so the counter argument to what I've been putting here today is that drugs have costs. There's no such thing as a drug that, and as I said, global fund's not coming to the kind of the whatever. So you're going to pay $30 a year to $50 a year, depending on what you can get them for, ongoing. But if we're monitoring your hepatitis B DNA via guidelines, you're paying stacks more than that, depending on where you are in the world. If you don't get cured, if you come off treatment, the virus comes back. So it's not curative. Drugs have side effects. There's no such thing as a drug without a side effect, but the reality is people have been on HIV therapy in Africa for years on tenofovir, combinations, and really the reality is the side effects are minimal. If you stop taking medicine, there's a risk of a flare, but as I'll show you in a moment, that risk of the flare is really low. There's a really simple way to manage a flare, put people back on treatment. And drugs remind you that you have disease and infection. Well, there's a lot of things that can remind you that you have disease and infection, and I'm not saying everybody has to take them. My view is an offer of treatment. So this is some work done by, just remember this Alex Thompson is saying, but treatment is not curative. So if it relapse, a whole lot of people get their virus back. So I have no problem with that. But my answer is, so what? We treat a lot of other non-curative diseases after assessing risk and benefit. HIV, diabetes, hypertension, raised cholesterol, cardiac disease, arthritis, the list goes on and on and on. Okay, so it's, why should we be being exclusive about hepatitis B? Oh, we're not going to cure you. I just asked the question, like most people, there'll be a number of people on this room on cholesterol medications to lower a risk of a disease where it's really, really low to get it, like sort of your CVA or your cardiac event or whatever, relative to a hepatitis B therapy of the risk of it. Side effects and flares, yes, they happen. But as I said, flares occur when people stop treatment, but the level of flare was really low in this work by Alex Thompson and put people back on treatment. So it's not that difficult. It's not like this fear of the flare in this uncontrolled and massive way that most people seem to talk about. So where to from here? Chinese guidelines are much, 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 much simpler. WHO guidelines, haha, I put a blank there. I'm not allowed to tell you. So there you go. But again, hopefully they're going to be much, 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 much simpler. They're coming out, what, second quarter next year? March, hopefully. And I will say they are much simpler. It could be even simpler still, but there is, let's put it this way, there is wiggle room in terms of how they talk about the availability of a hepatitis B DNA test and also what the approach score would be. So they will be much simpler and hopefully this will help us shift the dial. But at the end of the day, my view is who should decide on, I'm not saying everybody has to go on treatment. I'm talking about let's consider the offer of treatment. Because in my view, the person with hepatitis B should be the person who gets to choose. They should be provided with the information, the pros and the cons, and it should not be government regulation, or in my view, clinician knows best regulation that stops their choice. My view is the clinicians should provide support and guidance to help them choose. Our job is not to restrict choice. I'd like to acknowledge the people that provided this with slides and various things. Thank you.